So welcome, Cecile. Thank you so much.
Thanks, Anna. So hi, everyone. I'm Cecile, and I'm calling in from Canada this morning. And when Renata and I were chatting this morning, one of the things that's pretty normal in the Canadian context, especially in British Columbia, where I live, is to do land acknowledgements. And I often use land acknowledgements as a way to get connected to where I am in the world and just where I want to be. Let me share my PowerPoint. That's always a good place to begin. This is actually what it looks like where I live at the moment. So Londolozi might be plus 35. It's -7 here. So the opposite. And today, to sort of get us situated here, I'm calling in from the traditional unceded ancestral land of the Ktunaxa Nation in the southeast corner of British Columbia. And land acknowledgements is about more than the land. It's about what each and every one of us are willing to do to bring reconciliation to the world around us. And so what I'd invite you to do, and Amanda, I think you're in the perfect place because you're already outside, is maybe if you have a window nearby, just look out at the land around us and maybe get your feet on the floor under you. And I'm just going to read something from a Canadian writer by the name of Richard Wagamese. And this is a piece of a ritual that Richard talks about in his book, One Drum. So just get your feet on the floor. And the first thing is just to feel connected to the land. This is not Richard, but just feel connected to the land. And then here goes the reading. When you feel embedded in that sense of connection to the land around you, open your eyes and begin. Begin with the things that come easily to you. Offer thanks, tobacco ties of thanks for your health, family, home, work, school, friends, and possessions. Then breathe deeper and try to feel what other things in your world and experience you are grateful for. You'll find lots when you're properly centered. Maybe you're thankful for having 10 fingers and 10 toes, to be able to hear, to see. Maybe there's a skill or an art you carry. Perhaps you're thankful for the teachers in your life. The more you focus on the energy of thankfulness, the more things will come to you. And as each does, put a small pinch of tobacco in a small square of cloth and tie it with a string. So when you run out of things to be thankful for, just come back to this moment, and then we'll begin. Okay. So we'll do a check-in in 2 slides. The first thing that I was just going to say is in medical settings, when I present, I'm asked to sort of have a disclosure slide. And it's probably a good idea that I do that here. The one thing that's not on the slide is I am no Enneagram expert, people. I am just somebody who uses the Enneagram in my work. The second thing is I come from a background in family medicine. I coach full-time now, and I am a coach in private practice, and the data comes from my practice. So it's a very limited data set from people who seek me out as a coach. So you may notice that there may be some themes that arise from that, the flaws in my data set. The second thing that I'd like to ask is that we have some agreements. So, even when I was thinking about land acknowledgements, I grew up just outside Cape Town. I grew up in the Strand. So just even thinking about land acknowledgements, there are different cultural things between Canada and South Africa about how we talk about land. And so when things arise, we're an international group, we're going to talk about healthcare, which is something all of us have experienced. I can talk about my physician population, but all of us at some point have been recipients of care. And so sometimes things are interesting to talk about and sometimes we disagree, but let's apply the most respectful interpretation to what we hear in the room. My data set is not huge, so I've tried to sort of keep it as confidential as I can, but please let's share our own stories and try to be as confidential as possible, because I'm also going to ask you to talk out of your own practices, because I'm really curious about the patterns that you're seeing. And then generosity and curiosity, let's just practice those two principles of coaching as well. So here's the data. So it's 27 Canadian physicians. They happen to all be Canadians because I'm in Canada. 19 of them are family physicians. I come from a background in family medicine, and I think that's why people seek me out. And then 7 specialists, and this includes some family physicians who have focused practices in palliative care and gerontology and oncology and all sorts of things. And it's just over since 2019. So this data set actually is this sort of pandemic data set. And so just so you know, so a little bit more breakdown, mostly women. So clearly 70% of my practice are women. And it's been an interesting conversation to sort of notice the differences in material that men and women bring to coaching, even though they're in the same profession. And then also the impact of the profession on the person based on gender. There's some evidence from Shanafelt, is the person who did most of the work on burnout, and a big struggle for women in healthcare in general is the negotiation between work and life responsibility. And resolving that in favor of work has a much bigger impact in the lives of women than in the lives of men. And so, it's interesting when I try to sort of think through what happens for different Enneagram types based on gender when we think about professional environments. So this was the first thing that I thought was interesting. Sort of 2/3 of people are sort of in that moderate integration sort of zone. Nobody's really above that. Nobody's really below that. It's sort of just everybody's clustered around the middle. So people actually are somewhat self-aware. I heard a statistic yesterday that 95%. Renata.
Oh, so I didn't mean to cut you off in mid-sentence. I was just curious if the integration level is as per the measurement in the IQ9 report or your own sense.
Yeah, no, the IQ9 report. My own sense is, I think on a day-to-day basis, my own sense, it changes as people sort of go through things. So I just used the report. So I've lost my train of thought. I think what I heard a statistic yesterday that 95% of people think they are very self-aware, but the actual statistic is about 15% of people think are self-aware. So, when I think about this integration statistic, I thought it's really interesting that, when physicians do get a lot of feedback about how they show up in the world, and that might be why they know a little bit about themselves. So these are all the types that showed up in my coaching room. So a third are 2s and a third are 9s. So Catherine, you and I are in good company. So I thought this was like, I noticed something was going on in my practice and I couldn't figure out what it was. And then I started sort of thinking about like, what is it that I'm seeing? And when I went back to the Enneagram types, I looked at the men and it's a fairly standard distribution. I got a little bit of everything. And then I looked at the women and this happened. And so it's interesting that that idea of being helpful and supportive really comes out very strongly in women in medicine. And I have a theory that selection processes might actually bias who gets selected, especially into family medicine. That idea of being helpful and supportive is part of what makes selection committees say, yes, we want you. Whereas men have more permission in general to show up in diverse ways and be accepted into the workforce. Renata.
I'd be curious to know if the 7s, how many of them have social instinct? Social instinct is the sacrifice, who would, be other serving, not self-serving.
Yeah, both, if I remember, both of them. No, I've got one self-preservation, one social. And the social 7 is in a senior leadership position, which totally aligns with she's there to change a system. She's not there, to be individually changing things, which is very interesting.
And as Nian pointed out, this is the positive outlook or avoidant harmonic as well.
Yes, absolutely. So, so as Renata has demonstrated, please weigh in and share your observations or questions, because I just kind of put the data together. So what we're going to do is do a little warm up, get around the campfire. I'm going to put you into breakouts. Stephen, before I put you into breakouts.
Thanks. I just noticed that out of everybody, the 4, 6, 8s, the emotional realness types are all missing.
Yeah. I know. Isn't that fascinating?
Mm.
I have a theory that especially 4s and 8s within the culture of medicine have a hard time in the non-surgical disciplines. So I don't have a lot of surgeons in my practice. I don't know if that's because surgeons don't get coached or because surgeons get coached by other people with surgical backgrounds or different backgrounds. But in surgical culture, 8ness would fit a lot better. And in some of the specialties, uniqueness would fit a lot better. But especially family medicine is a very sort of, it tends to be a very sort of conflict avoidant, calm, let's just calm this down, let's nobody panic kind of culture. And I think the 4ness and 8ness might not fit, and therefore people might not be selected. And there's so much selection bias that I think that might be, but yeah, it's interesting. I noticed the same thing. 4, 6, and 8 is, you don't see a lot of flashy shirts at medical conferences.
I did coach the surgeons that are the heads of unit surgeons at our children's hospital, and the team, as the team in particular, and some of the individuals, and there were no 8s and 4s, but there were a few 6s. And what was interesting is every single one of them in their tri-type had a 1 action style. and most of them had a 2 feeling style, except for the 3s. But yeah, they you know, and I thought, how appropriate if somebody's cutting your baby's head or heart open, you'd want them to have a 1 action style.
Yeah, so we are going to talk about action styles in a little bit here. So I'm going to put you into breakouts, and let's talk about just what surprised you this far. What do you notice? So how does this align with your experience? And I would invite you to think about your experience in terms of what's happening in your practice, and what's happened when you've accessed healthcare or when you've provided care, because I know some of you have provided care as well. And what's your theories about what might happen for patients and providers in the systems that you travel in? So we'll do about 15 minutes, and then we'll come back. Renata, I've put you in a room. Do you want to be in a room? Oh, no, I have not put you in a room. So you can move yourself accordingly.
Perfect.
Any questions before I send you off to outer space? Okay, so what did you talk about? What did you learn? What would be useful to share in the bigger group? Who would like to kick us off? So there was a room with Alistair, Amanda, Anna, and Catherine.
This is unmuted.
Yeah, I can go. I'm not surprised at all at the female in sort of family medicine. You know, 9s and 2s are the other reference, service orientated people. And in England, I taught people going to university, and I taught psychology and health. So a lot of the young people I taught who wanted to go into midwifery, nursing, whatever, they did have the actual vocational element to it. There was something in them that actually wanted to serve from quite a pure place, really. So what's interesting is the fact that it's how it changes with the gender, the gender. And I know from the selection process of universities, well, here in the UK, I'm wondering whether there is that gender bias, that the females are, the males can be a bit more disagreeable, bit more, so that's quite an interesting. So the female one, no, it doesn't surprise me, but how it changes. Now we know it's a small sample. So that would be looking at, as you say, the interview boards and how they're interviewing these young people to get into medicine. Mm-hmm. And as I say, that was something I was involved in, trying to help people get to university. And it's very competitive in the UK to get in to be, a doctor, extremely competitive. So yeah, that was very interesting.
Thanks, Teresa. Yeah, it's very competitive everywhere, and it is interesting. I was wondering about that. There was a Harvard Business Review article about women having to bracket with warmth, and I wonder how that plays out in selection processes for all the professions, not just in medicine. I'm imagining in all professions where there's competitive interviewing, there might be an element of gender bias, and all the other biases. If let's not make it just about gender, it's about all of it, all the biases.
I'll say in my limited experience with my physician team, the women were 9s and 2s.
Mm-hmm. Mm-hmm. Isn't that interesting? What else came up that you talked about that's interesting? Yes.
Well, I was in the room with Teresa and Stephen, and I was saying the first thing, of course, I'm relating this to is my husband's GP practice, and there's 4 partners, and my husband has done the IEQ-9, but the other 3 haven't. But, he has a suspicion on what the other 3 are. My husband is an SX2. The other male partner is a type 9, or shows up very clearly as a type 9. We don't know, but of course, because he's not been tested, but so much of his behavior is a type 9. But the women are what I found curious, because it's so different. There's a type, what we suspect is a type 3, very, you know, maybe with a strong 2 wing, and then a type 8. Because she is so different from the other 3. I mean, very, very, loves the control, loves the, you know, and, you know, yeah. And so, but we were discussing, maybe is she a type 2 that's in stress a lot, you know, or something like that. So my husband wants me to come in sometime. He would love it if I had the opportunity, and I might do that, you know, and provide you know, them all with the Enneagram if they're open to it. But I was just thinking about, how much with the pressures that every doctor, but GPs being frontline in the UK, they have to deal with 85% of all things. Mainly they have, you know, just such a, you know, patient load, how much of their behavior is changed because of the stress that they're under. I don't know if some of your study has taken into consideration, you know, how, you know, they move into their stress, you know, behaviors as you've worked with them.
Yeah, you know, definitely one of the recurring themes in coaching has been a lot of the 2s that go to 8 under stress, and the impact of that on getting along, not with patients, but in the practice environment. You know, I only used people who had done the Enneagram assessment, the actual IEQ-9 assessment. And I know one of my cohort of people who hasn't done it is definitely a 1. And that has had so many impacts on just getting along in the practice, because they've got a very specific view of how it should go. And when it doesn't go that way, it gets really challenging. And it's very challenging for a group of predominantly 9s to give a 1 challenging feedback about behavior. So it's interesting, you know, how our type plays out in the practice dynamic of just how do you, because it's a small business or sometimes a big business, and how partners get along, you know, especially when we're all 9s, and we're going to talk about action styles later. You know, it creates a lot of problems, shall we say, and a lot of opportunity, but it creates some challenge for sure. Thanks for that, Tiffany. Anything else that, yes, Alistair.
Yeah. What surprised me was the disproportionate sort of allocation on the graph to, say, type 3s. What I would have assumed was, based on like my background and my environment, is like type 3s would be attracted to the medical profession because it's financially rewarding, similar to like maybe your 8s and 7s as well. Like when we grew up, like the sharpest kids, everybody said, you're going to be a doctor, you're going to be a doctor, because there was money there. So I'm curious, in that community, how financially rewarding is the profession compared to like maybe working in a bank or investment bank or something like that? Because that could maybe have an influence on the distribution of the types. And also, that being said, like linking it to the Great Resignation, where a lot of people are frustrated because maybe their Enneagram type is not suited to the job they were in. And maybe these are some of the 9s and 2s who really want to help. And then they're stuck in some, you know, Wall Street kind of desk job. And also what I found was the nurses would be lots of the type 2s and 9s, but it wasn't as rewarding as the doctor's side. I grew up in Zimbabwe, so that was a big thing, where you've got these aggressive types being your doctors, and then your nurses being in the helper type role.
Mhm.
No data on this, it's just observations and opinion.
Yeah, absolutely, Alistair. And that's one of the reasons why I said, like, my data set is definitely family medicine, which is universally across the world the lowest paid of all the specialties. And you know, when I look at like the surgeons that I work with and the orthopedic surgeons, there's a lot of three. There's a lot of three there. So, you know, and there's also huge gender disparities between who gets into the highest paid. Like 1% of the representation in the highest paid specialties are women. It's such a clear gender bias because it's men that select other men who look like them, and it's incredibly biased in that way. So I agree with you. I wonder whether threes would actually look at the training that's required to be a physician and go, that's actually very inefficient. I can make the same amount of money much quicker doing something different. Stephen, I'd love to hear your thoughts.
I think I'm talking from lived experience with going to doctors. I think talking about efficiency and the three being, I think the 279, in a sense, disconnects from emotion because the 279, the positive outlook, moves things along. Mm-hmm. And they disconnect from emotion, the 468, hence no 468s, because emotion in that profession is draining. You want to remove yourself emotionally, which is ironic because in a caring profession, one associates that with the heart space. However, mm-hmm. It's not efficient to, it's draining if one invests too much in the heart space, I should imagine.
Mm-hmm. Yeah, I agree, Stephen. I think that is one of the strengths of 279 is that, and you can let go, especially the nines can just let go at the end of, you know, this bad thing happened, and my preference is actually to just move on into the future and forget about that really dark bit in the past. So yeah, isn't it fascinating how? Yes, Jill.
Sorry, I interrupted you there mid-sentence, Cecile. I don't know if you want to finish off.
I was just going to wax lyrical. You go.
Oh, okay. A couple of things that our group spoke about is the time versus money thing. I mean, in any practice, it's about the ka-ching, right? We all doctors and we all want to make as much money, and that means we have to churn the patients through as fast as possible. So I know when I go and see a doctor, there's like a 20-minute slot or whatever, and then it's quite efficient. Okay, so have you eaten this and how many headaches? You know, so the questions kind of come through quite fast. So I was curious about, you know, integrating this whole kind of psychological tool requires time and a different energy, because it's advocacy versus inquiry. You know, I mean, I would come to you, Cecile, because you're the expert, and I come to you for an answer, which is different to a coach, because the coach doesn't have the answer, and we don't want to have the answer. We want to help you find the answer. But I mean, if you said to me, Joel, so I mean, literally, where do you feel it in your body? Wouldn't that be hilarious? Because I mean, you're the doctor. So I mean, I'm curious about that time thing, because if you're really wanting to make a connection with someone, it takes a little bit more time and a lot of other questions, different questions that are not necessarily physical about the person's body. So there was that. And then I was also really kind of curious about this profession as a whole literally deals with life and death potentially, and must carry enormous stress. I mean, the stress of even making an incorrect diagnosis. So I was thinking of people at lower levels of integration who are perhaps more brittle with the polarities, and how they then process that, I don't know, making a wrong diagnosis with the baby, and then the baby gets sick and things can get bad quickly, you know. So that is I even get anxious just thinking about it. So those are just some of the thoughts that I had and that our group spoke about.
Mm-hmm. Yeah, absolutely, Jill. And, you know, it's interesting because a lot of my work now is at that intersection between medicine and coaching. Mm-hmm. And it's interesting, you talk about the physician as expert, and sure, I mean, that's part of the physician role. But one of the things, so we have 2 dogs, and we got them from the SPCA, AKA the Pound. So they are, they're thoroughly bred, but not thoroughbred. And my husband took the dogs to the vet one day, and he came back, and he's also a physician. And he said to me, I finally understand that look that patients give me. And I'm like, what look? It's that, that look when patients give you when they're definitely hearing you, but they're not ever going to do the thing you've just told them. And I was like, yeah. And he's like, yeah, the vet told me to brush the dog's teeth. And we live on a farm, so our dogs are out like eating whatever is out in the field, and that's the intersection between expertise and the willingness to actually understand. And the medical model has placed so much emphasis on the expert role, but so little has shown so little interest in understanding the person who has to take action on their own behalf. And I think, the 279 is actually well positioned to make that transition, to really help people understand, yes, this is what we know about your health, and what is it that we can support you in actually doing about your health without telling you to go and brush your dog's teeth. So I think there is room for less of the myth of busyness is one of the myths of medicine. Everybody has 24 hours a day, and all of us have on average 4,000 weeks. So doctors choose to be busier in some way.
Thank you.
Nien. Yeah, Nien.
Yes, thank you. Well, what that brought up for me is in this program for caregivers, I mean, the question of how do you get caregivers to do self-care, is a big question, right? And a part of infusing the Enneagram is this idea that I was like, you don't just give a gratitude practice, you tailor it to at least 9 different languages of like why I would want to do this, It's something about that in the understanding. I mean, not to manipulate. There's a subtle line, right? Of like, oh, if I know you're a rational competency type, I might speak in the language of solutions. And if you want that, then you might want to try this. And then I also, the word like intercept keeps coming up for me, like where, especially with what I do, I was like, I try to teach people to meditate. It's like, my God, busy people, to like encourage them to meditate. And it really is like beginning with this, like, well, let's review. So what you've been doing, the way you've been doing it hasn't worked for you, right? Like, are you willing to try a completely new way? It's like, it's a risk, it's a venture, but like that kind of, I found that can open them, right? Versus like, there's something about even the way they'll approach the coaching context, right? Or the consulting context is in their own way. And if I can break that and say, well, that hasn't worked, and you've tried it and you've doubled down on it and it still doesn't work. So what about just experimenting with that way? So that's what came out for me around that. Really interesting. I also wanted to add earlier, I had the question, and forgive me if I just missed it because of my unusual lack of presence. If you shared, Cecile, your subtype or earlier today.
I'm an SX9.
Okay.
Yeah. And I have a 9. I'm a 259 tri-type.
Okay, thank you. Yeah, and I'm just curious. It's still an inchoate like idea, but like more and more, like I'm seeing like organizationally how the instinctual biases like impact this. I think sometimes more than type. But I also have found that, like as I talk to more and more Enneagram colleagues, I mean, I think some of you touched on this today, like how often our particular group, the people drawn to us, have to do with either our types and our shadows, right? Like there's something I have to work on, but just kind of, I was like, oh, is this Cecile's group of people? Like these 2s, the 9s and 7s, and apparently not so much 8s, and just kind of thinking about that for each of us and what we draw to and how we're uniquely suited to serve a particular population, It's be curious to get like, what's the set, if we all threw in our numbers here with all, you know, our people, and what would that look like? So just kind of thoughts I'm having around this. So thank you.
Yeah, Nan, you're not wrong. Clearly, I am the 2-9 whisperer. But it's interesting because in my personal life, I actually tend to surround myself with 3s, 8s, and 5s. Because yeah, I really resonate deeply with 3s, 8s, and 5s and their way of being in the world. And they bring so much out in me that I don't have access to. So it's interesting that in my coaching practice, I have this real preponderance of people a little bit like me. But it's actually like you saw my slides, because here's the next slide. You just talked about instinct. And so 2/3 of people are actually self-preservation. I don't know why the other 2 blocks aren't showing up, but the SX is 15% and social is 20%, 18%. So this kind of surprised me, because Renata and I were actually talking in the break, and Renata was saying like, yeah, I totally see this. They're interested in health. You know, Renata, I'll leave you to speak for yourself, but you know, but my vision was never, like as an SX9, my vision was never to sit in an office and sort of consult and have a receptionist. And like, I was going to sort of work on a team in war zones, saving the world, you know, because of that intensity. And I started my work career at Frere Hospital in East London. I worked there for nearly a decade because the intensity of the work, this very service orientation of really serving the people who had very little or very limited access to good care, just was really meaningful to me. And that's all team-based because of the way it is, by necessity. And so, you know, it's interesting when I look at this, it explains a lot of the patient experience. Because the instinctual style that struggles to connect on an individual level is the instinctual style that leads. So I'm trying to squeeze in the extra breakout room so we can talk about like, how do we apply all this to healthcare, to patients? So I'm going to skip the next breakout and show you this slide instead. So here's the other thing. When I looked at just, you know, which of the centers of expression comes first, over half of people have lead with feeling. Which it's a little terrifying. People feel first, then they will think, and then sometimes they will act. And some of those action styles are actually single-digit numbers. Like quite a few of them, about 1/3 of them were single-digit numbers, which is so interesting that, you know, we think of medicine as this profession that acts, and does. But in fact, people really struggle to take action a lot of the time and to know what the right thing is to do, to speak to your point, Joel, about, you know, and when the vast majority of people have 9 action styles, the impact of that, and, you know, to sort of prevaricate for 8 hours a day about, you know, what's the right thing to do here, is exhausting. So I've shown you that the sort of subtypes and what we lead with. Do you feel like chatting some more in your breakout rooms? I've changed it up just a little so that you get some new energy, but not enough so that you feel totally disoriented. Is that okay with the breakouts? All right. So all right, so let me send you off. So the question is just, how might all this stuff actually impact the people at the receiving end of care? And of course, you're all grown-ups, so you can talk about whatever you want to. So, all right, here you go. The best thing about breakout rooms are the smiles when people come back. So what did you talk about? Renata, I wonder if you wanted to say something about self-preservation and leading with feeling. We were just having a very interesting conversation.
So for me, you know, the self-preservation makes sense because, you know, health and well-being is self-preservation concern. And also, you know, certainly I would have imagined that considering a career as a physician, you think of yourself alone in your rooms. Like Cecile, I understand with the Essex instinct wanted to be on the battlefield, you know, that's pretty intense. But usually you think of, if I'm going to be a doctor, I'm going to be in my own rooms, in my own office, by myself with a receptionist. And that's how it's going to be. I'm not going to be part of a collective, you know, the interaction isn't going to be that intense either, really. You know, the person's going to come in and tell me, and then I'm going to listen to their heart and inspect and write a prescription or whatever. So it's not particularly, you know, so that makes to the self-pres makes sense to me. And then the centers of expression, you know, the leading with feeling makes sense. You know, it's people, you know, that do feel, and it's a stacking. So they feel and think before they act, which is pretty much what you want. I lead with action, and I don't want to, and I wouldn't even choose medicine as a career because it would just take too long to get going. You know, all those years of studying and stuff, like hell no. So you know, I feel that picture of a lot of feeling and thinking before acting is a great thing. I'd want that in somebody who's going to be taking care of me. That's my 2 cents worth. Let's hear from everyone else.
I'm just going to say in our group, because Niam and I are not, I'm narrative and Niam's, we're not trained in the integrative. So Stephen very kindly defined what action means in regards to the integrative, which was quite helpful. So I don't know if there's anybody else who's not from integrative who might need that, the centers defining, because it's slightly different to
yeah, so there's different. Stephen, I would love you to define it, but I just wanted to say, in Enneagram world, there's different views on centers of expression, and they're usually type specific, and IQ9 separates centers from type. Steve, go ahead.
I was just saying that for me, we were talking about walking the walk, authenticity, and which kind of led to defining action. And for me, I found that the word act from an integrative definition, because that's the model I know and I work with. The word action is not always accurate. It's more about that anger energy, that being present, that embodiment, that getting. And so I can do things in my head, I can be intellectual about something, but until I get it, until I embody it, which for me is then the action, it has more resonance. The action center there then has more resonance for me as an embodiment, being, presence, that that you can't define, that, you know, that anger energy, that passion. And I don't mean passion in the Enneagram sense. I mean, does that make sense?
Absolutely. Thanks, Stephen. Anyone else?
I mean, we were talking, you know, touching on something you just said, Renata, about the feeling and the thinking and our experiences as patients. You know, when we do come into our GP practice and you feel like they've, you know, your GP has taken time, they've really heard you, they've listened, they have that feeling, and then, you know, they're kind of figuring out that diagnosis, because, you know, they are the frontline people who see everyone before they refer on. And just the importance of that experience for us as patients to have that. And when we haven't had it, we maybe we've been in a consultation where the doctor is very rushed or just kind of fobs you off. It feels like, you know, it's just so different. And you know, so when they move into action too quickly, it's like, you know, whereas when you really been heard and, you know, then they move into action, it's really important. So I think all of us were saying that experience is really, you know, helpful to understand and kind of aligns with your research, Cecile.
Thanks, Stephanie. Jill.
Thank you. 2 things came up. So the one would be a little bit about what Tiffany said. So I know the experience that I like as a 1 when I go to the doctor. So I like enough warmth, but get to the point. You know, it's kind of like, tell me what I need to do, or what prescription I need, or what the problem is, or, you know, so, but I also notice when there isn't enough warmth. So there's like a fine balance, which is really hard for the doctor to figure out because they may not know me from Adam. So like, how do I be, you know? So it's kind of, how do they play that balance? That's the one. And then we had a few horror stories in our group about what we've experienced from the medical profession that was just not pleasant at all. And we were wondering, you know, whether there's ever been any research about how to integrate that learning. So obviously, I'm assuming as a medic, you learn about the body and you learn the technical stuff of how to do the diagnosis and the diseases. But then how does the human being get integrated, the feeling part? Because, for instance, in my mom's lung cancer diagnosis, the very first appointment we went to with the oncologist, we kind of met with the equivalent of like the empathy person first. I don't know what her name was, the nurse or whatever. And honestly, with
I think you just froze, Jill. You're on mute, Renata.
Yeah, Jill's frozen. Maybe she got load shedding. It's a very common occurrence for South Africans. She'll probably be back. We can move to somebody else. Stephen?
You know, load shedding is happening on the hour for me. So I'm gonna say goodbye ahead of time, just in case I also freeze down. Thank you.
Thanks, Stephen.
Thank you,
Okay.
sister. Thank you.
Thanks for coming, Stephen.
Thank you, Cecile, for a very valuable session. I really enjoyed it. And insightful. I got a lot out of it.
Oh, I'm so glad. Thanks so much. So, you know, we're 10 minutes away from the end. Jill, yeah. You're back. The generators kicked in, I guess, eh?
Oh, I'm so sorry for the interruption. The other point I quickly want to make is, as coaches, we have supervisors. So I can go to my supervisor and I can tell her all the difficult things I'm experiencing with the clients and also get advice on how to be and what's coming up for me. So I'm interested to know, I don't know, do medical practitioners have that system where you can unload and be supported?
So the answer is, in the UK, there's actually a very well-developed supervision practice amongst the medical profession, which is not true in North America. And as far as I know, in South Africa, when I practiced there, it wasn't available there as well. So I've actually cheated and used my coaching supervisor as my supervisor for my medical practice, because the same confidentiality applies, but I can work through the clients that really challenge me. So we've got like 10 minutes left. I wanted to show you just one more interesting slide that's interesting to me. These are the tri-types that came up in my data set. So if you look, the 952, you know, the 9.5s, 9.6s, and 9.7s is actually 71% of the data set, which is just very interesting. These are the sort of actual numbers for the action style. So mostly a 9 action style. This was surprising to me, mostly 7 thinking styles. And then obviously the 2 feeling style is very predominant and very prevalent. So yeah, we all made it through. I survived presenting. That's a good thing. What more should we talk about today before we all go home?
I'm sure there'll be some reflections on these last few slides. Let's just look at them very slowly.
Okay.
Yeah.
So,
on the action styles, so lots of 9 action styles. I'm wondering how that would manifest. I mean, so there are a lot of 9s.
well, there's a lot of 9. There's a lot of people with 9 in their tri-type for sure.
But even if they aren't a 9, their action style is 9.
Yeah. And, you know, which is interesting because, you know, one of the things that I personally experience as a 9 is I spend all my 5 thinking energy thinking about the sort of like, shouldn't I part of, what's the data? Should I do this? If I do this, what's going to happen? If I don't do this, what's going to happen? So I think a lot about the conflicted action, which I think is exhausting, and I think in part contributes to burnout, where people spend so much cognitive energy trying to do the right thing or do the best thing or just figure out what to do. Yeah. Michael, I'd love to hear your voice. You haven't said much today.
Just thinking about what can we do? What is it we can do? And I've been in hospital environments on the receiving end with a renal stent, a cardiac stent, and some orthodontics over the past year. And I've had a lot of practice with being in those situations. And I just think, what can we do? What do we take courses in or get people involved and stuff? And okay, what have I done? And even though I'm 5SX, I'm counter type, but what I noticed is the more I connected through my heart with the clinical person, the more responsive they were. So I was more relaxed. I was making contact with my heart, breathing and whatnot. And they would relax too. Not always, but they would relax too. And they would become more considerate toward me, which is what I was looking for. So I don't know, maybe that's next time we get in a hospital, lead with your heart, and there may be a response. Oh yeah, I'll join you there. Oh, hi heart. Maybe.
Yeah.
Just a thought.
Thanks for sharing that, Michael. And it's lovely to know that lots of people do lead with their hearts. And if we open our hearts to each other, there's lots of possibility for connection. Being a 9, and one of my core values is inclusion, as Anna will know. It's a nightmare some days. Let's finish here. We started off with bringing everybody's voice into the room, and Catherine, as much as it's painful, would love to leave with everybody's voice in the room.
And I'll pause the recording at this point. So
okay.
Cecile, because we'll thank you at the end, but for the recording.
Okay. So there's 13 of us in the room. We have 5 minutes, maybe 4.